Good morning. It is still morning. Welcome to UW Green Bay on this beautiful day. I know there'll be additional people coming in, so please feel free to eat because we want you to have a good experience, and full belly, and enjoy the great presentation we have coming up. So I want to welcome you to today's Lunch and Learn, where we're going to discuss strategies for delivering effective health messages during times of health crises. We're going to spotlight Dr. Phil Clampett and Danielle Bina's work funded by the Tommy G. Thompson Center on Public Leadership on how to strategically communicate during health crises, a guide for Wisconsin political leaders and healthcare officials. The guide drew on lessons learned from the COVID-19 pandemic to provide practical strategies that help leaders and healthcare professionals navigate the complexities of public health messaging and improve their strategic communication efforts. You will find materials on the table to the left of the stage, but I also want to draw your attention to the program that you should have picked up when you came in. There are some QR codes on the back cover where you can go right to the Tommy Thompson Center and find the videos and other materials there. So we're really, really excited that you could join us and look forward to an engaging and interactive session. A little bit about the Tommy Thompson Center. Clearly, they are an important player in today's session. They were the sponsor and partner with UW Green Bay, and we really thank them for their support, as well as the center staff of Alex, Ruth, and Lily. For those unfamiliar with the Thompson Center, I'll say a few words about it. I'm sure there's no one in this audience who doesn't know Tommy Thompson, or if you do, please take the time to get to know him. He was a very, very progressive and influential person and continues to be an influential person today. In fact, he was very instrumental in providing funding for a lot of our nursing students to provide vaccines during the COVID pandemic, and also to provide some funding for those who are working in the front lines of healthcare. And we couldn't be more grateful for that work. The Tommy Thompson Center was established to follow in the footsteps of Tommy Thompson, who really worked on both sides of the aisle to advance the public good. And this is a good example of that. The Thompson Center seeks to carry on his legacy by informing and inspiring current and future public leaders, fostering leadership skills, and promoting effective public leadership. And so this event is just a good example of that. So we're very grateful for them and appreciate their support during this time. Next, I want to introduce Dr. Phil Clampett. Dr. Clampett is the Distinguished Professor and Blair Endowed Chair of Communication at the University of Wisconsin-Green Bay. He earned a PhD from the University of Kansas, specializing in organizational communications, public relations, corporate communications, and social media. Dr. Clampett has won numerous awards for his teaching and scholarship and is renowned for his innovative teaching methods. His students started calling him Dr. So What, because he asked so what so often that as a way to prod and encourage them to think about the implications of their ideas. He embraced the moniker and created a website devoted to improving critical thinking. Phil has consulted with companies around the world on leadership and strategic communication issues. The Wall Street Journal highlighted his work on decision downloading, which details how companies can effectively communicate decisions to those not involved in the decision-making process. Probably an understudied and undervalued strategy. Most recently, his articles in MIT Sloan Management Review on the hard truths about the meeting after the meeting and 5 ways leaders can turn pushback into progress have gained accolades from around the world. He has written numerous books on communication, leadership, and uncertainty management. His latest book, Leading with Care in a Tough World, was co-authored with Bob DeCook. Dr. Clampett's contributions continue to shape the field of communication, preparing future leaders to navigate complex organizational landscapes with confidence and insight. And I will now turn it over to Dr. Lampitt to introduce some of our panelists.
Well, thank you very much, Christine. When we were getting ready for this panel, I was advised to talk to Christine. I was the first person to talk to, and she said, and when she heard about what we wanted to try to do, she just got so excited. And I hope you don't mind, but I'm going to tell it. I felt like I had just called Gruber Law, and it was one call. That's all. And
That'll be my moniker.
no, I'm not advertising for Gruber Law, but I'm just saying that was at one time. So I'd like to introduce, and then she volunteered to get some great panelists, some of whom I've just personally met today. They're great, and we have some great panelists. They've all volunteered their time because they're devoted to creating good public health messaging and good health public and providing good public health in a variety of ways. So they volunteered their time. Just one program note, we have a lot of students in the room, and I know they have class at 12:30, so some of them are going to have to scoot out at certain times, so don't let that disturb you. But we will carry on and go to about 1:15 or so, which is what we're scheduled. And we'll allow audience questions and things like that. So without further ado, let me just introduce some of the panelists that we have. My first is my co-author and worked on this project along with Kaylee. Where are you, Kaylee? Kaylee's over here. Kaylee was our research assistant, and we worked on this project. And Danielle is a teaching professor here at UW Green Bay. Many of you in the audience know her because you're former students. She's also worked at several television stations, including WFRV and WLUK. She's won numerous awards, including a National Telly and Associated Press and Wisconsin Broadcasters Association. So we're fortunate to have somebody with such practitioner skills and commitment to our students working for us here at the UW Green Bay in our program, in the communication program. The second person I'll introduce is Tom Zalaski. Tom and I have known each other for how long? Many years. I've still got his picture posted in my office. He looked the same as when he gave it to me 20 years ago. And Tom has anchored the newscast for 47 years. I think I worked with you at least the last 20 years or so, right? And he's covered local, national events. He's a speaker, an MC, an author of 7 books, one of which I've read actually, and I forgot to bring it today, but it's a great book. It's about what was the last one you gave me? Was how to influence the public, or it was a politician book, right?
It was How to Manipulate the Media for Fun and Profit.
Yeah, it's a great book. It's a fun book. He also has a guitar, and he has a local rock band, and he also has a 12-acre farm just up the road from us. So he's a really great, wonderful person, as well as a great newscaster, and so we're very happy to have him. So please welcome Danielle and Tom. And then the third person I'm going to introduce is Dr. Mike Shattuck, who gave up a fishing trip with Dr. Resop over here to be here with us today. And so Mike and I have got to know each other for many years, and he's semi-retired physician. He actually treats patients, treated patients during the COVID. He's provided full scope family medical care in central Wisconsin, and emergency room physician. He currently works part-time at the addiction clinic and volunteers at Pregnancy Center, and also works for the local food pantry. And the really interesting part, I think one of the most interesting parts, is not only a physician, he's also part of the school board. So he had that kind of connection. And we found a lot of issues in regard to the school board when we were doing our original research. So it's just a fantastic, thanks for doing it, Mike. Thanks for doing it, Tom. And thanks for helping us out. So with that, I'll turn it back to Christine.
Wonderful. So we are really privileged to have such a great, esteemed group of panelists. I'm going to introduce Tina Schneider next. And Tina actually is the Vice President of Clinical Services for the Rennis Group, bringing over 3 decades of experience and a steadfast dedication to the post-acute care sector. In her current capacity, she's responsible for overseeing clinical operations and ensuring the consistent delivery of high-quality resident care across multiple facilities within the organization. If any of you are unfamiliar with Rennis, they are a very large, multi-faceted facility that provides amazing services. And we are very fortunate to have our nursing students complete their clinical in their facility. Tina began her nursing career as a certified nursing assistant, which is a lot of ways that nurses begin their career, paving the way for progressive roles as an RN, assistant director of nursing, and a regional nurse consultant. She's also served as a state regulator for long-term care, which is a really hard but important role. And you can gain a lot of insights into both clinical care and healthcare regulations. For the past 12 years, Tina has been an integral part of the Rennis Group, bringing clinical leadership, quality improvement, and regulatory compliance. She's also a wound care certified registered nurse and holds a particular focus on wound care management, which is really important in those settings. Her commitment to clinical excellence and her dedication to fostering a culture of compassionate care have really played a key role in shaping the Rennis Group's reputation for high quality services. So thank you, Tina. And she did a presentation to our students on the image of nursing, and it was very wonderful. In fact, I remember that very fondly. Next, I'd like to introduce Sarah Pearson, and Sarah is a registered nurse and director of nursing at Aurora Baycare Medical Center with 25 years in the profession. As a certified critical care registered nurse, she worked in the ICU and as a flight nurse during her early career. In the last decade, her focus shifted to nursing leadership, and she's a board certified nurse executive advanced and has led teams as they navigated the challenges of the COVID pandemic in the hospital environment. She made a point of ensuring her staff were well prepared to handle emergencies with clarity and confidence. Sarah is deeply committed to creating a culture of psychological safety for nurses and fostering an environment where they feel supported and empowered to provide the best care possible to the patients in our community. And I'm sure if any of you remember, I was talking to one of the panelists saying, it feels like COVID was 20 years ago, and it wasn't. Maybe that's my psychological safety trying to say, push it back. But anybody who had to navigate direct patient care during COVID deserves awards. I'm also very honored that Dr. Charles Seepers, he also goes by Chuck, is with us this morning to provide insights from the public health side of the aisle. Dr. Seepers is the health officer and director of the City of Appleton Health Department with over 20 years of experience working in and supporting local public health practice in more than 10 states. His training is in using behavioral science to improve social policy and built environments to improve population health outcomes. Certainly something that we need more and more of today. His work has spanned leading community-based participatory evaluations across diverse national diabetes prevention and treatment programs to understanding the social mobilization impacts of community response efforts to the Ebola outbreak in Western Africa in 2015. His hobbies include camping and hiking with his wife, Jess, and 2 spirited dogs, a golden retriever named Bailey and a Westie named Gus. And during cold weather months, he can be found playing tabletop war games and painting sculptures. That sounded really interesting. The painting sculptures you have to tell me all about. So we are very grateful for each of our panelists for their time and dedication to their fields. And now I'll turn the podium or the mic over to Dr. Clampett, who will kick off our panel discussion.
Thank you very much, Christine. You did a great job, and thanks for being our Gruber Law. We got a great panel. We'd like to focus today, and everyone on the panel is committed to kind of making sure that we do a great job in communicating about public health in the future. Our study showed that on average, the general rating on a 0 to 10 scale was 5 for the way in which the communication was handled, particularly at the federal level during the our COVID pandemic. And so what we'd like to do is to take the lessons learned and project forward about how we can be better at doing that, and hopefully start to to shape those in a way that is going to do great help with a great deal in any future health crises we might have. And so that's what our focus is. That's what all these folks are here to do. They're committed to doing that. And so it's really cool. So we built the panel around this idea of this is draft week, right? And so you should have footballs at your table. The panelists have footballs. But the most important draft, we think, in one way, is the draft that we make of our public health messages to make them more strategic and make them better. That's one commitment we have today. And the second commitment we have today is to help deliver those messages in a positive, uplifting way that resonates with the audience. And so we have a distinguished panel that allows us to do both draft better messaging and then deliver them in a way that is going to resonate with the various audiences. And I think that's a commitment we all have here. To start things off, we're going to show you a quick video that summarizes the research that Kaylee and Danielle and I have been doing for the last 2 years and is sponsored by the Tommy Thompson Center. They gave me a hat. Because they've been great at sponsoring our research, and we just thought we'd give you a little preview of that, all which is available if you click on the QR code that's there, and you can download it or watch the great videos that Danielle prepared, and they're fabulous to be used for teaching and moving forward. So without further ado, my students know that are in the room. We always give a drum roll before a world premiere. So drum roll, please. All right, this is a literal world premiere, never been seen before.
Effective communication relies on great strategy. It helps focus and prioritize, anticipate and plan, leading to a way to shape and guide the dialogue.
And if you just start with the tactics, you're going to end up with a hodgepodge of different things that don't necessarily fit together and tell an overall story.
Great strategy in health communication is based on a number of factors.
The essence of strategy is it breaks to the clutter to grasp the essential. And the clutter, particularly in a healthcare crisis, is misinformation, disinformation, social media. The essential is the long-term messaging that you're going to need to be successful.
So where do you start? First, survey the landscape or communication terrain.
Second place on top of that is to say, look, what are the publics or audiences that I'm going to be communicating with, and what are some of their issues and concerns? And if you get those two analytically done in the right way, then you're going to end up with a really good strategic plan for communication going forward.
This chart identifies some of the communication issues during the pandemic and what could have been done to mitigate them. There were a number of identifiable issues, such as a highly polarized electorate and distrust of experts and institutions. There were also issues related to scientific uncertainty.
And if there was one major failure that happened as a result of the communication, from my perspective, was that there was an unwillingness to allow people to understand that uncertainty and learn from it and actually use it in a positive way. In fact, it became a more negative thing rather than a positive thing, which it should be. Science is always progressing.
Another important consideration, health and science literacy.
According to the Health and Human Services, only 12% of Americans have proficient health literacy scores. In fact, to give you one specific example, 80% of most people who go to the physician will forget what the doctor tells them. And then 50% of the patient remembers something inaccurately the physician tells them. That tells you that in general, our health and science literacy is not as great. We also see the scientific illiteracy part because people don't understand that the uncertainty that's implicit in any scientific enterprise.
And widespread social media influence in real time affected the accuracy of the information.
Many people were getting their information from the social media because it was quick, and frankly, it exploited anxiety that people were having. And somebody needed to put calming influence on that and deal with that official channel and even a social media channel that people could rely on, because over time, the credibility would start to wane for these anxiety-producing types of misinformation, and hopefully the credibility of the more thoughtful people, the people that knew what was really going on in terms of the vaccine and in terms of COVID infection, start to go up. You have to play that game, so to speak.
So what are some of the key takeaways? One-size messaging doesn't work. Tailoring messages does. Failing to anticipate the terrain leads to ineffective messaging. Understanding and legitimizing the multiple audience reactions builds credibility.
Prior to having a crisis like this, you really got to get your ducks in a row and think about who we have coalitions with. Number two, you have to have a way of thinking about how you're going to formulate a strategy during the crisis.
Last, practice.
Best thing you could possibly do is practice some examples of how you would be on television, for example, how you would deal with a social media post that was outrageous. Those types of things, and the practice creates more sense of empowerment on the part of the health communicators. They aren't caught off guard.
Oh, thank you. Yeah, that's one of the videos that's out there that is on the Tommy Thompson site. There are two others that are there are actually four others, right? Four others. We have five total. So all those can be used in instruction and moving forward. But we want to go beyond those studies. We just wanted to set the groundwork with these studies and then tap into the expertise of our panel here. And I'm just going to go down the row, and I told him it was going to be rather organic, but we're going to start with a basic question. And that is, could you describe, what COVID was like when you were the communication challenges you faced during COVID, and then what are lessons learned moving forward and that you think we need to make sure we do? I told some of the panelists beforehand, I'm going to throw another one out there if you want to take a shot at it. If you were to give the CDC one piece of advice, what would that be? So we'll leave that out there, and we'll let you just go. And so Mike, he was supposed to be fishing today, but we're going to fish his mind for some great ideas today. So Mike, cast away.
Fun. Okay. Well, thank you for the introduction. It was quite generous. I'm not any award-winning person or what I would consider an expert, but I was involved with taking care of patients during the time of COVID, and hopefully I can share a few things that I experienced during that time that were in my role. My role was an emergency room physician. I was trained as a family physician, worked many years at that, and seeked some more predictable hours and got into emergency room work and was doing that during the time of COVID in a small community hospital. So the needs from the communication for me initially was what is this that we're being confronted with, and what are we going to be able to do about it, and is this something that's going to happen right in our community, or is this something that's, like we've heard about before, something that happens across the world? And I had read about the SARS viruses, the severe adult respiratory syndrome that had occurred in other countries prior to COVID-19. And then when COVID-19 gets its name from being the coronavirus that was discovered in 2019, this was a novel virus, meaning that no one had ever seen this virus before. So my response was, okay, what do we do? How do we diagnose it? How do we treat it? And my very first thought, I have to admit, is, oh, maybe it'll just stay over there. We won't see it here, which obviously was quickly obvious that it was coming to our area. The personal experiences I had was that a good friend, right at the very beginning in March, early April, had been in contact with the people who returned from a trip and was fighting for her life in Fond du Lac in the intensive care unit. And this brought it home very quickly that this is something that we're going to be exposed to and have to deal with right here in rural Wisconsin. My communication was maybe a little different than other people. As being a staff physician, I was working under the Theta Care organization, and we had a administrative physician who was sending out daily email communications to try to keep us up to date on as best they could on what was known. And much of this was being relayed from what the CDC was telling that person. And as providers, we had no choice as far as staying home. We knew we were out there, and we wanted to learn about how can we protect ourselves, and then how can we diagnose and treat the people that are coming in. And one problem it very quickly was that the testing was not available right away, and eventually we got the ability to test and be able to diagnose better. The treatment was there really wasn't any treatment, and we can get into later how that led to some problems because there was no accepted treatment, and people were searching for something that they could do. I did fall back on some of the basics of healthcare, in that no matter what you're treating, you can always look at your patients and say, I have to deal with what's the serious, go from the most serious to the less serious. And we knew that we could support them. And first, are they breathing? Do they have a pulse? Do they have a blood pressure? And of course, start with those things, but work your way down. And we could treat them supportively, but initially we really had no effective treatment. And trying to communicate with the Theta Care system to identify those people who needed the intensive care and work with them to do the best that we could until more treatments were developed. I did lean back on some advice that I might share that I've carried with me through my career as a resident. When I was first in training, one of the senior residents gave me some advice about how to absorb information. And he told me, which I've kept with me, when you are told something by someone, you can believe it most of the time, but be careful about what you're told. What you read, you can believe more of that, but still be a critical thinker. And then he said, if you observe something yourself and it makes sense, it makes logical sense, you can pretty much hang your hat on those things. So as I was practicing, I was being very careful to try to observe what was going on. And it became obvious pretty quickly that some of the things that I was being told didn't jive with what I was seeing. And then having the personal experience of doing everything to try to protect myself, wearing the mask all the time, doing those things. I woke up one morning and it was through my granddaughter, actually. He says, "Doesn't this smell terrible?" And I said, I couldn't smell a thing. So I said, "Oh." I went in and had a test, and I was positive for COVID. And fortunately, I wasn't sick. I wasn't sick. I just couldn't smell anything. But realized that this COVID problem was probably much more widespread than we realized, because I wouldn't have even known I had it had I not lost my sense of smell. So I was trying to look at what people were telling us, what we were seeing, and do things come together. And I think that the part of being a critical thinker, as you mentioned, has to come into play, because there was my sources of information primarily, as I said, were through the Theta Care system, but I listened to the news. And I'm old, as you can see, my gray hair. The social media was something that I didn't use very much, but I saw so many people being distracted by things that were coming out on social media, and I think that was a real challenge for people to be able to filter through what information was correct and which was.
Yeah, you were one of the first physicians we interviewed for our study on that. you kind of put on our radar screen the idea that you were getting messages from above that were saying one thing, but your observations were saying different things. And so resolving that conflict turned out to be a difficult challenge during COVID, which maybe we could move to Tina now and see what, if you had the similar experiences or what lessons you see going forward. And the lesson we just talked about, critically thinking about what we're getting, is certainly something we're all committed to, I think.
Yes, for us, it was very difficult to kind of weed through the CDC recommendations, what was being presented during the news. The media outlets were reporting information that was sometimes a little bit different from what was actually published on the CDC website. They were a little bit behind getting that information out. So for us to try to write global policies that were going to be effective for all of our communities, so we have 13 buildings, throughout the state. And, we had also the staff that were fearful to come to work. So trying to manage, making sure that you're communicating with your staff what we were doing and with your residents and their families, and keeping everybody comfortable with, how it was evolving, was very difficult. And, we would have morning calls sometimes twice a day. And, and I had to really start to be comfortable with telling folks, this is what we're doing. This is the guidance. Here's our updated policy. And maybe at 4 o'clock in the afternoon, I was saying, forget what I told you this morning. We're doing something totally different now. So as that was changing so rapidly, to try to make sure that everyone was on the same page with where we were today and what was the guidance this hour, and trying to support our residents. As I don't know if you all remember, but the guidance from CMS, which is the Center of Medicare and Medicaid Services, which regulates long-term care, instructed we needed to close our doors, so we could not have visitors. And that impact of trying to communicate that to their loved ones and keeping them informed of what was going on with their loved ones, and trying to be that support to them, and how we could foster and continue to have those relationships, was very burdensome and difficult. And people didn't really realize the difference, and I don't know that they still do, between how we're regulated. So we obviously have the CDC guidance that we need to follow. There was the World Health Organization that had some guidance that was helpful at times. And then we also have the regulations, the regulatory body that dictated some of the steps that we had to take. So pulling all of that information together and communicating it out to make it make sense was challenging.
So anything you would do differently than now that you've been through that experience, you're dealing with the same issue with lots of conflicting information. There are things you would do differently now?
I think, starting out, being very upfront that, it's ever changing, and what we're doing the best that we can with the information that we have right now, and making sure that everyone knew that it's going to change. Our COVID policy, we had 48 updates to it in 2 years. There's not another policy that I've had that's had that many updates. So I think, making sure that people knew. What we started to do later on was have bullet points, because as you said, people don't remember the information. So when you have a 30-page policy, it's very hard to decipher through. So we would bullet out, this is what the takeaways that I need you to know for today, and highlight those changes in our policies. We also created action plans that staff could grab and go right through. I did that, I did that, I did that. And I would do that very much earlier than we did initially.
So Sarah, you want to jump off that with that same kind of, see if you had the same experience or different, or how you handled it?
Yeah, absolutely. So working in the hospital environment, I remember our first scare. I was like you, hoping that this virus wouldn't come here. And I think we all had that hope in the back of our head. So it might have even delayed our planning a little bit, because it didn't feel real. But that first patient scare that hit our hospital, and we were like, what do we do? And I was at the front lines helping people get into their protective PPE and figure out how to use things like poppers and making sure they had the right size N95 fit tested mask. And it was, luckily, this was just the scare. The first patient was not positive, but it was a real wake up call, and it was a real wake up call for our entire staff. The fear was real when they came to work, and I can only imagine what that was like for the public, as I was too involved in the operational pieces on the day to day and trying to make sure that the nursing staff and the medical staff in general had what they needed to protect themselves. They came to work knowing that they were putting themselves at risk, and they also felt like they were putting their families at risk. So I had some nurses that were living in a camper outside in their driveway, and I had some nurses that would try to stay at a hotel and maybe not go back to their house in the beginning of the pandemic until we really knew what was going on. So I think our biggest challenge was managing the fear and making sure that we had the messaging and that we were sharing the information to keep them safe. And it was really hard because of how fast paced the information changed. Even so, I can imagine from the public's perspective that also was challenging for them to grasp. But when we were changing as often as Tina said, daily on what our recommendations were for keeping them safe, not to mention the PPE shortages that were at risk. So, we had to do things like reuse masks and put them in paper bags. And it was really challenging. And then what we quickly discovered was we needed to share what our visitation policies and guidelines were, and those were changing every day as well. So we put that out to our staff, but we had to make sure that the internet matched, because that's where people were going for their sources of truth, was right to the internet sites for the hospitals or the organizations. I think, it was a top-down because of everything was changing so quickly. We had a communication style that was almost like an incident command structure, where the CDC would give guidance, and then our hospital senior leadership team would get together. They'd review the guidance, they'd make their changes, they'd have daily and sometimes twice a day meetings. And then we had to provide that support then to the frontline people who are taking care of the patients. And I think at first, the nurses were celebrated. They've been often cited as a most trusted profession in some of the literature, but and they felt a duty and an obligation, and they felt celebrated. But I think as time wore on and the pandemic didn't go away as fast as we were hoping to, I think they felt that sentiment changed, and they didn't feel quite as celebrated by the community as they needed to. I think one last point I would make would be that as far as the communication, I felt like with the in the media and to the public, I felt like they often had physicians who would speak to what they were seeing. And I think that was good. They were able to break that down a little bit simpler. But one of the techniques that we used was almost like a fireside chat within our organization, where our hospital president and physicians and nurses would have a panel discussion much like this. And we would video it and share it with our entire organization to really help connect the pieces of what was going on and how we were providing our support, where we were getting our information from. And I felt like it was really a connecting point that helped everybody get on the same page.
Do you think that helped manage the uncertainty that everything was changing? So actually talking about the uncertainty by having different voices as opposed to suppressing it was a better choice. Is that?
I think that helped our team, and I think that could potentially help more if we could do that for the public.
Yeah, it seems like just the opposite of what we were getting at the federal level sometimes.
Yeah.
So Chuck, it's a good segue to move to public health, and then we'll get to Tom and Danielle, because they'll tell us what it felt like in the media perspective. So Chuck, you're a public health officer, and they've taken quite a few hits in recent years. So maybe you could give us a little insight about how it affected you and what your lessons learned are.
Sure. And I'll just start by saying I had come to the city of Appleton in February of 2022. So I was in this role in a different context, but very similar sort of challenges, from a communication standpoint. And I think that just to build off of what we were just talking about, I think that whether it was communications or operations or any sort of challenges we can think of, those challenges were different at different stages, right? So in the first pre jurisdiction COVID case, there was a lot of fear from it was a small rural health district, 4 counties, 53,000 people. Physicians were very concerned about things, but also had some time on their hands to offer some suggestions in a small rural context, and so that presented some interesting challenges. And I think that. Sorry about that. There's just different challenges at different times. I think that once we got into really fall of 2020, trying to communicate with school boards and school superintendents, just again to sort of piggyback, I think the trust from public health was at its highest in April 2020, and then. In the state, I can't talk. The state of Nebraska, where I was, we did not do stay-at-home orders. There wasn't anything like that at the state level, but it was thought through that the best course of action by schools was to close schools, and so. Very similar sort of timeline, but since our constituents were the general public and so many different sectors, employment, work sites, and so large plants in terms of meat processing, manufacturing, that kind of thing. There was the need and the desire for tailored solutions for their context to keep as many people safe as possible was needed. And so not only were we consuming all of the changing CDC guidance, which was happening in those early stages very quickly, but then to try to communicate that not only to the general public, but then to provide special, tailored plans and that kind of thing. But so I'd just say that the changing of that messaging once we got into the vaccine context in early 2021, then we had this sort of pushback already because people had already begun to become armchair experts in vaccines at that time and COVID in general, and so those were different challenges and just presented different ways in which that made that work hard.
Yeah, I think that's helpful. We're going to get into hopefully how we restore public trust a little bit, and maybe we'll just take a different slant now and go to our media experts. So Tom, maybe you could talk a little bit about, I know in your interview, you talked about some of the challenges you faced, and I don't know if the audience is familiar with the challenges that you face, particularly in the media, and Danielle can speak to that as well.
Well, first, thank you for inviting me. This is quite the privilege to be here. Feels like old home week for me because former competitor here, Danielle, against me at WLUK TV while I was over at 2. And then Dr. Phil, of course, is our political consultant on election nights at Channel 5. So he makes sense of all the chaos coming in from the polls. So it's wonderful to be with these two. When Danielle first invited me to this, I was so excited. But then I looked at the list of the other panelists and their credentials, and I was scared to death. I go down the list here. Charles here, heading up Appleton Health. Christine, Director of Nursing at GV, Sarah, Director of Nursing at Aurora, Mike Shattuck, an MD, Tina, Vice President at Rennis. And then I said to myself, I read a teleprompter. What am I doing here? Well, I hope I'll be able to add something today from the media perspective. Another reason that I'm so thrilled to be here. This is the highlight of my week because beginning tomorrow, Wednesday, Thursday, Friday, I am going to be stuck in draft hell. I will be broadcasting from Lambeau Field at 4, 5, and 6 in the midst of food trucks and loud bands and drunk people, all while trying to intelligently interview the governor and other dignitaries. So this is great of you to have me here today. I surveyed my colleagues in the newsroom as to the challenges that we had faced because it was some time ago and we all had to kind of put our heads together, run through a kind of a list of what we all came up with. Many of our challenges were literally hands-on and logistics. First of all, we had to immediately learn how to do Zoom interviews because you could no longer interview people in person. Our assignment manager, Ed Walters, had to interview 13 people by Zoom just in one day. So we all had to learn Zoom very, very quickly. We also had to come up with new angles on stories every day. Here we had just one story. It was COVID. But we had a 4, a 5, a 6, and a 10 o'clock show. And each show had to have a new angle on this. And people were frankly getting bored. It was only this one story. I had an issue with my co-anchor at the time, Erin Davison. Not an issue with Erin, but I mean, I love her to death. At that time, as you well remember, the rule was to stay 6 feet apart. And normally Erin and I would anchor shoulder to shoulder. Well, they told us you now have to be 6 feet apart. But we had another built-in problem. I don't know if many of you know this, but Erin Davison is the second longest living recipient of an organ in the state of Wisconsin. And she is compromised, extremely compromised with all the medication that she is on. So not only did she have to stay 6 feet away from me, I couldn't get near her. And so what happened is they put Erin on the main anchor desk and they threw me across the studio at this little kindergarten table desk. And that's where I anchored for about a year. But we had to deal with that. Our reporters in the field, they had to deal with wearing the mask. And here they are trying to do their stand-ups through a mask, and nobody could understand what they were saying. Same with the people we were interviewing. They were wearing masks. People couldn't understand what they were saying. Then we all had to use those big boom mics because we couldn't get close to our interview subjects. We had to reach over and 6, 7 feet away, try to do that. I also do a Sunday morning show called Newsmaker Sunday. I tape that at Thursday at about 2:30 in the afternoon. Our guests, first of all, couldn't come into the building for about a year. And when they finally could come in, again, it was this 6-foot separation, which doesn't make for a very homey, comfy interview. It just looked awfully awkward. Then from a content standpoint, news that we were covering, we would go to a meeting that some of the medical people would hold, and here came the anti-maskers. I'm not putting politics into this at all. It was just a fact of life. We came to a meeting to get information from the health officials. And even before the meeting started, the maskers would take over the meeting and disrupt it. And that became the story. We came back to the station with the anti-masker disruption story, and viewers never got the information about COVID that we were there for initially. And then finally, businesses blamed us for causing them to close down, or we were driving people away, and we were simply passing on the information that we had. The main theme that we have heard here, and I'm so glad that everybody is saying the same thing, mixed messages. That was our biggest problem. Mixed messages coming from Washington. And again, politics aside, but here we were at news conferences, and I had the President of the United States saying one thing, and he, of all people, has access to every bit of information possible. He's the boss. He would tell us one thing, and in the next breath, 2 hours later, Dr. Anthony Fauci, Dr. Deborah Birx would be telling us something completely different. And I'm sure you all remember that one famous news conference where the president was giving some information and the camera panned over to Dr. Birx, and the look on her face was one of terror. She was like, no, that's not true. But we showed that to people at home, and the viewers at home looked at that and said, okay, he said that, she said no. What do we believe? And that trickled down to the poor health professionals locally. We would go to you to get interviews about what to say, what to tell our viewers, and you were getting mixed messages, and you really didn't know what to tell us. So that was the main issue that we had to do. Beside logistics, it was getting that mixed message.
Do you want to elaborate on that a little bit, Danielle, from our study and from your experience as a newscaster?
Well, I would echo a lot of, and I did most of the news media interviews for our studies because of my background. I was not, to clarify, working as a journalist during COVID. I was here teaching. But one thing that most people don't know about the pandemic, and as a former journalist that I do know, is that journalists were considered essential workers during the pandemic. You may or may not have known that, which means Aaron, as the recipient of a liver, immunocompromised, needed to show up to work. I have other friends in media, and so do you at Channel 2, immunocompromised. And they had to be there. So they were considered essential. I think the hardest thing, and in all the interviews that I did, there were some commonalities. One being health literacy issues. So you have varying health literacy issues out there, and journalists are chief sense makers. They're not making the decisions, they're not making the call, but they have to take all of this information and make sense of it for a public or multiple publics that have, ranging from no health literacy to a very high-end health literacy, depending on your background. Now factor in that most journalists, just because they graduate from J school, don't have any health literacy as a result. We're not taught health communication. Like, we have a great health comm emphasis at our communication program here at UWGB, and Dr. Turkowitz is with us today, and she heads that up. But most communication programs don't have that. So you were sending people out to cover extremely tough stories, and they didn't understand themselves. And then in some of these briefings, they were using jargon and the spokespeople. So one of the common complaints that I heard from a lot of working journalists at the time were, train your spokespeople. Speak in English to us like that don't understand health issues, so we can make sense of it for the other people who don't understand. And a lot of times, some of the briefings, particularly at the state level, locally, it seemed like they fared better in terms of the responses that we got. But on the federal level and on the state level, I know the briefings, sometimes reporters were allowed one question. And a news director in another different station than you in town said to me that was a total disservice to the public. Because what do we do as journalists? We ask questions. We ask until we're annoying. That's what we do, because that's the only way we can get the information, make sense of it, and then translate it for our many audiences of varying literacy levels. The average, and Tom, and maybe this has changed, but in all my years in journalism, we were in television particularly, because it's spoken, it's broadcast. We were told to aim for about the literacy level of a 12 to 15-year-old.
You're right there, because I was always told 14.
Yep.
Yes.
That's the average. Think about that. And then think about a tremendously complex communication issue such as COVID. Then think about the fluidity. It was changing all the time, minute by minute. And then think about the top-down style that they were getting, where some of the experts, particularly at the federal level, I think, were basically a top-down style of, I'm the expert, this is how it is. not admitting what you don't know. So that was the other complaint that I heard uniformly, routinely from all of the, and I interviewed close to 34 or 35 journalists in locally and statewide. And they said, why couldn't they just admit what they didn't know? We don't expect them to know everything. So, and there was one really notable quote from one of the journalists who said, they think that's a sign of weakness. We perceive that as a sign of community. So those are some of the other things that, you know, from my experience interviewing some many of the journalists, and you could speak to that as a working journalist during COVID better
No,
than I.
even though you've been out for a while, you hit it right on the head. Yeah, that's exactly what we went through. Yeah.
One of the things that is emerging from the panel so far is this whole issue of that intrigued us from the beginning, which was about the uncertainty. You get it from mixed messages from, you know, really the highest levels of government. And then you get the mixed message of, like Mike was talking about, I see something that in my clinic or in the office that's different than what I'm getting guidance on. So you get this kind of thing. And then you layer on top of it. A third one is the science is always changing and emerging day in and day out. So this is a huge amount of uncertainty, which is something Danielle and I and others have studied for quite a while. So what I'm curious about is, given this highly uncertain and ever-changing nature, how do you deal with it? Or more specifically, if you have a client or a patient, or in the case of a TV viewer who just wants to know what to do, tell me with certainty, how do you go about talking to them about the fact that you really don't have it for all the reasons we just laid out? And I'll just leave that out to anybody. If you want to start, Mike, you're the one who brought it up first, so you get the responsibility to go for it. And then I don't mean to go row by word, whoever wants to take it.
Well, I think that the uncertainty was fueled by the inconsistency of the messages we were getting, you know, to mask is not going to be effective. Okay, now mask, now wear 2 masks. Now we've got this vaccine and you can go out and be in the public without a mask, but now you're vaccinated. Oh, no, you can't. And there were things that from a medical point of view were inconsistent. I'll just use my personal experience. I told you that I came down with COVID. This was before the vaccine was available. And at that time, they were using antibodies from individuals to treat COVID patients. So here I am going in, donating my blood, giving my antibodies to treat this, for other people to be treated. And when it came to the vaccine, they said, you have to have the vaccine. And I said, well, okay, but don't I already have the antibodies? Well, yeah, you do, but we're still going to make you have the vaccine. And it seemed that some of these issues, these types of issues, the experts stuck their head in the sand and said, we're not going to listen to logic here, because from a medical point of view, there was no reason for, I was already had the antibodies. So those sort of things, I think, fueled the uncertainty with the medical providers, which spilled over into the general.
Would anybody else like to jump in on that? So you talked about how it fuels it, and it's compounded error is what you see over time. How did you end up dealing with it ultimately to start restoring trust in the public and public health measures? I'm going to throw out a question in a little bit about the physicians that I've interviewed that say vaccinations these days have taken a nosedive because of literally about the COVID communication as the primary one. I don't know if you were the first one to put that on my radar screen. My brother did. He's a physician as well, but others have put that on my radar screen. So anybody want to take that? I mean, where do you go with that? How did you end up ultimately dealing with this uncertainty coming from 3 or 4 different certain places? And you had patients who were saying, or parents or clients who were saying, hey, I want to know what to do.
I can speak to that. So for us, it was really just having those one-on-one conversations and going through our policy and explaining where we got the information from and allowing them to just vent and showing that empathy that we're all in this together. And, so cliche, right? We're all in this together with COVID, but it was just taking that one-on-one time and communicating and over communicating where we could. I mean, I know I got calls at all hours of the night, on the weekends, and would take those calls just to have those conversations. Let's talk it through. I don't have all the answers. Let's make the best decision that we can based on the information that we have. And I think just taking the time and being available helped for us.
I would echo Tina, and from an organizational standpoint, we just had to put more people in place to answer all the questions. We were lucky enough to be able to just take somebody who worked in one role and move them into another role so that they could provide that 24/7 question and answer piece for both some of the visitor questions that came up and then some of the treatment. But just like the public, our nurses wanted that. I want to know what to do, but then they got the mixed messages as well. So the one-to-one communication, I think, was just really essential.
Do you think it was inevitable that there are mixed messages in this environment? I mean, is that just inevitable because of that? And if there is, there are going to be mixed messages for any number of different reasons. And how do you manage patient expectations or the family expectations in light of that fact that they're going to hear conflicting information?
I think there's a cross between the need to act quickly to make sure that we have all the best practices in place, and the need to listen and hear from other health experts who are saying there's confusion here. This doesn't make sense to us. Why are we doing this? So it's that incident command. We need to get everybody on the same page doing the same thing, even though we don't have all the answers. And how do you message and still do that at the same time?
Right. And that's the central conundrum that we
Mhm.
looked at. I don't mean to go down the road, but we are going.
Yeah, no, and I think that works well. So for us, as we were in a sort of joint incident command, 4 counties, multiple health systems, having that joint information center was critical for us, and we determined early on, or we all came to the same thought, is that we would have one source of what was truth, and so that was us as as local public health. And so as soon as we learned something, we would put it into the Joint Information Center space. And so all hospitals would have the same information at the same time. We were having calls with our federal partners, sometimes 2 or 3 times a day. Those state calls were about the same sort of time frame. And so things were changing rapidly, but we had information that no one else did. And so we were looked at as the primary source of what truth was. And locally, at least, we didn't have any. There wasn't much conflict in terms of what info had gotten out.
Tom, do you want to jump in on that too?
Yeah, I'm not a doctor and I don't play one on TV, but I would implore my television station in the future, if an incident like COVID ever happened, I would implore them to bring on on a retainer a local doctor and have that person as our spokesperson at the end of the day who could make sense out of everything that we had heard the entire day.
Would it have affected, I mean, one of the things that came out from talking to media, and Danielle did most of those interviews, was that they felt like they had to cover the political feuds on the one hand, but then at the end of the day, the people watching television wanted some answers. I mean, is that kind of what your answer to that is, that they wanted somebody to turn to with high credibility and not the drama of the politicalization of the COVID?
Right. I was kind of hoping throughout that whole COVID that one day, someday, all the medical professionals, local medical professionals, were simply going to say, let's black out what we're hearing from Washington. Let's all get together, our staffs, our medical people, our spokespeople. Let's all get on the same page. And based upon what our local doctors are telling us, let's come out with one unified message for this day. Because remember, our local people, they trust you. They really do. I mean, they go to you for surgery and broken legs and cancer. they trust our local medical community. And so if our viewers were to hear one unified message, they would trust that.
Danielle, did you want to jump in?
Well, media, your competitor did that, right?
Thanks.
Sorry. And I think they did. They partnered with Prevea, I remember, and they had Dr. Ryan.
Yeah, Ashok, right.
Yeah. And they did fare well because they had that one uniform voice, and he was always there and he would take questions, but not everybody got that lucky. And so there was I interviewed an editor of a kind of a community weekly newspaper in central Wisconsin. And she had tried to get any information out of the health system. Now, I don't know if you know what's going on in central Wisconsin, but they've lost a lot of healthcare facilities and whatever's going on. You guys would know more than I would. That came after, but during that time, they were shut down and shut out. She would continually call for information and they would just say, no comment, we have no comment, we have no comment, and would not partner with them. And that's tremendously frustrating. So those partnerships, I totally agree, in hindsight, for everybody, really made a difference. The other big elephant in this room is social media, and we haven't touched on social media. So it's bad enough for the healthcare providers. I'm sure when you're seeing patients every day and they say, well, I heard that if you take this horse pill that you can, that'll, so I'm sure you were fighting that. Media also have to respond to all things social media. And social media was creating all kinds of narratives out there that were absolutely ridiculous. And it became a red and a blue virus, depending on what. And so then the pushback started. And of course, social media is a democracy and you can push back, and people did. And that must have led, I mean, for you people, especially, to a tremendous burden. But for media, I know that it did, because that was another one of the interviewee responses that was frequent.
Looks like Mike wants to jump in on this one.
The social media part of it, I was going to comment on, because the difficulty, as you already pointed out, is the health literacy of the average individual. And I guess one thing I would say to students here is that what I saw was the supposed science that people were presenting was based on correlation. And what I mean by that is if a group of garlic farmers hung a necklace of garlic around their neck and they had the same type of response that I did to COVID, where they got better, they would be certain that garlic is the cure for this, because that was their experience. But just because there's a correlation, that doesn't mean there's a causation. So to be a critical thinker, you need to be able to think about, does this correlation really mean that there's a cause or not? And I think that that's a difficult thing to communicate to the lay people, but I think that's what led to the social media people filling the gaps of these questions people had, because the government, CDC, didn't have all the answers. And as they were trying to come up with the answers, this gap was being filled by the social media and many things that they may see a correlation, and so they say, well, this is the answer, and it made it difficult to provide information to people when you're being flooded by some of this misinformation.
Sarah, did you want to jump in on that too? Does it look like you're shaking your head in great agreement?
There's a little delay. Yeah, the social media was, I think, the teams that were taking care of the patients. I say nurses a lot, but I mean the entire medical team, so forgive me. They felt that they could see that happening. And I don't know how well the general public would respond to that causation versus correlation message. Like that's teaching that, it kind of is higher level. It's above that 14-year-old age range. But I think, we were blessed with some local physicians and medical staff who made themselves present on social media and were trusted and shared their own interpretation of that. So I always like to look at the positive side as well. But it was problematic, but then there was some offset from that.
Or even that simple example about the garlic, wearing the garlic is enormously helpful. Communicate to the lay public about causation versus correlation, for example, that all of us in graduate school had to be schooled on again and again and again and again. But one of the things that it did encourage, that I keep hearing, I don't know if this is true, so I just wanted to get your reaction to it, is it seemed like from the study that Danielle and I did, and Kaylee, that it started off that everybody was paying attention to the federal government. And as the pandemic continued to go, over the years that it took, that we became more and more reliant on local government and local media and the importance of that. I don't know if that's true. I just remember we were dealing with a family issue in Oklahoma, and Lori and I took a trip. We drove down to Oklahoma, and it's like we're wearing masks the whole time, and it's like, we got to Oklahoma. There's no COVID here. You're like, who are these crazy people wearing masks? And so when we go in public places, I should say. But I just wondered if you saw that too, that there was less dependence on the national media as time went on, and national policy, and more on local. And if so, does that give us a way out going forward, thinking about the power of local media and local relationships, like Tom just alluded to, and Danielle? So I just wanted to get your thoughts on that.
Yeah, we know what the medical professionals were going through. We were very aware when we called you folks for an interview. We knew that like 8 minutes ago, somebody may have just died while you were at their bedside, and you're understaffed, and you're overworked, and you're stressed out, and you got PTSD. And then somebody like me gets on the phone and goes, "Can we interview you?" And you're like, "You have no idea what I'm going through right now." And trust me, we were well aware of that.
Yeah.
And that social media you mentioned, it's easy to get burned. I got burned yesterday on social media. I woke up yesterday morning, first thing I saw on my cell phone, the Pope is dead. I went, yeah, right. Because I said, wait, he just did Easter Mass. This is a hoax, until I saw enough information about it. But it's easy to get fooled. Can I mention one thing to the medical professionals here in dealing with the media? Little inside advice. If the media calls you for an interview, don't be afraid to ask the reporter, what are you going to ask me? Now, reporters do not like to divulge the questions they're going to ask ahead of time, especially when you're interviewing a politician, because you want to ask that zinger question, that gotcha question. But in the case of COVID, when it's a medical emergency, you have every right to ask that reporter, tell me what you want to ask, because this is too important. I want to know the right answers. I want to research the answers. I don't want to hem and haw. I don't want to guess. I don't want to say, I'll get back to you. I need to tell you the right stuff right now. Now, if, as some reporters will respond, they'll say, well, we don't give questions ahead of time. Your response has to be, then we don't give interviews. And you hang up the phone. I will promise you one thing. After you hang up the phone, you're going to get a call back in 5 minutes, because that reporter has just gone to his news director and said they wanted the questions ahead of time, so there's no interview. And the news director says, we need that story. Call them back. And you'll get your questions. But if you're ever running for office, you're not getting them.
No risk there.
Chuck, do you want to jump in on this, or?
Yeah, and I think that the challenges that social media posed, obviously affected all of us in different ways. We had like county sheriffs that were basing actions that they were doing based on posts that they would see and and that kind of thing. The other thing that became very challenging in terms of what the social media sort of pose, and I guess this gets back to the other question of was trust shifting from the federal to the local. In my experience, that trust shifted very, very quickly. And locally, we were considered to be experts very early on. I think that it took that, nearly that full year for people to be like, okay, well, this isn't that bad, right? Because the idea of, 7% fatality in some areas, folks don't have a strong understanding of what that looks like. That being said, I think that's when social media really became, the bane of everything that we were trying to do, because then that, I had a brother that had COVID and, was just fine. So this isn't a big deal. There was more of that cavalier attitude the longer the pandemic had gone on within that, that early 2020 to fall of 2022. And that's where social media did the most damage, I think, is after, we started to get into the vaccine space, and right. And so then everyone became a vaccine expert, and then, right. And so, and just on and on. So I think that, in terms of what those challenges were around social media, it fueled a lot of things that we had to deal with, including there's a lot of, patriot freedom groups that would lead anti-public health campaigns, and in so much as offering death threats to folks in the space and that kind of thing. So all of that perpetuated from social media, and without social media in the space, I think it would have been a lot different in terms of operations on the ground, at least in our public health context.
Tina, want to jump in? Oh, Mike wants to jump in with your garlic.
I can remember what I was going to say, but the problem with you saw different areas where, like you said, I would go to visit my daughter in South Dakota, and was like taking a vacation from COVID, but in no way, even because my experience with COVID personally was mild. I don't want anybody to think that COVID was not a terrible thing. It was terrible. I had friends and acquaintances and took care of people who died of COVID. I mean, we lost 1.2 million people. We had well over 100 million cases of COVID. So COVID was a terrible thing, and I don't want to downplay it at all. But as far as the communication of it, it from a medical point of view, when I look back at it in hindsight, now that we can look back, we went through all these things that we did to try to prevent the spread, to try to get vaccinated. And as it turned out, the herd immunity idea that people poo-pooed initially was what ended it. It didn't end it, but it got it under control. When in January, December of 2021, January 2022, that those people had been vaccinated and were wearing masks, they still got it. And that spike was what brought it under control. And that now that we can look back at that, if you would have suggested that to some people at the very beginning, there were only a few that thought that would happen. And that's what it turned out to happen, even though some of the experts didn't think that would happen.
Yeah, Tina, I want to jump in. I told you I was going to ask you about the CDC. If you were going to give some advice to the CDC for when these types of issues occur in the future, my sense is that we're going to get even more uncertainty when it comes to public health information because of changes that are going on in the health field right now with who's in charge with Bobby Kennedy. Am I saying that right? Yeah. But, a lot of things that, like with the autism studies and all these different things. So you're going to see a lot of conflicting advice coming out, I suspect, in differing studies and contention, some of it political, some of it medical. What advice would you give in this environment to the CDC? Because that seems to be the place where most of the information is gleaned that many people start with, at least.
I would say it would have to be concise and flow, that it was easy to read and easy to decipher what the guidance meant. So it was very confusing. It was very different when it came to long-term care versus acute care, and the virus was the virus. So I get the comorbidities of, the elderly population was a little bit different, but it was very hard to pull all of that together to figure out the steps that you needed to take. And then as that information changed, they wouldn't necessarily highlight what those changes were. So it was reading through it. Okay, what did I read yesterday? I had to print it out and highlight it so I could try to figure out what was new today. So I think, even creating some type of dashboard that you could go day by day, what is it today? Let me look back and see what it was yesterday, so I know how I need to communicate to my staff on what the changes are and what are the big bullet points. So being concise and maybe having more of a bullet point outline than all of the verbiage that they had.
So our time is drawing near to, I want to make sure we have time for a few questions. So I'm just going to go down the line here and ask each of the panelists, because this could go on forever. I just love hearing what you have to say and your experiences, but I'll start with Danielle and then go all the way back. We'll end with Mike. And just say, if there was one piece of advice about how to better draft and deliver strategic healthcare messages, what would that one piece of advice you would give? Even if it's something you've already said, I think it's worth kind of summarizing it before we go to a few questions from the audience, and we'll have to wrap up at that point, but I'm sure the panelists would be happy to chat with you.
One piece of advice. Oh boy.
I know you have many, but
No, well, in this issue, there's so many. I guess in terms of drafting communication messages, my biggest piece of advice would be understand your audiences. Number one, who are they? What do they know? What do they think? What do they believe? What is their disposition? What are their pushback points before trying to communicate in a one-size-fits-all approach?
Yeah, as we were saying, this whole conversation, get on the same page. And even to the point of, no matter what Washington says, no matter what the CDC says, do it, give your information based upon like what the good doctor said.
well,
Locally,
local,
what
Tom. It
we
sounds
have
like it's
discovered locally, this is the advice you should be giving.
now. That's why that's one of the things that I don't know if it's true, but it seemed like to us that as the COVID went on, that people became less and less reliant on Washington and more reliant on local experts. I don't know if that's true, but that's what it felt like. Is that what it felt like to you, Danielle?
I think the other point there is, and Tom, actually was going to ask you this if we didn't have time up here, but a lot of the journalists felt that the early communication in COVID was too data driven in terms of body counts over the actual information that would have been useful to them as a human being. And multiple people said they needed to humanize it and walk us through this mRNA process, walk us through how this works. Just don't shove it in front of us.
Chuck, your piece of advice.
Yeah, so we all have a bias from where we sit, and I think that the most impactful messages are done in a partnership, right? Like our perspective of what is the most helpful info is only one aspect of that. Is it culturally competent? Is it does it take into account our various language context? Does it does it resonate with target audiences, right? So part of what we had seen in my context, in my health district, we had 18 different languages. Certainly early on, that information was changing so quickly that it was difficult to get it translated into Spanish, let alone Congolese, right? So, but having those different perspectives as you're crafting that important information is critical to this, and I think it tags on to the local perspective, the theme that we're starting to see.
Thank you, Sarah.
I feel like a lot of this evolves around trust. And I think finding as many different ways, and you mentioned humanizing and you mentioned collaborating and getting on the same page and using as many of those tactics as we can to make sure that we're maintaining the trust of the people that we're talking to and trying to care for.
And I would echo that. And I think being resilient and showing compassion.
Well, what I would say has to do with what people already alluded to, the trust factor. And to be very specific, what I would say is that when you have your main spokesperson for the country as a polarizing individual, as people were seeing him as being polarizing, he should have stepped out and let somebody else come in that could gain that trust back, because in my opinion, he had lost trust by that point of so many people that it was hurting more than helping. And if he would have stepped down and let somebody else in who could have tried to regain that trust, it would have helped.
Okay, we have time for a few questions now, and from the audience. And Kaylee, where are you? Kaylee's got the microphone, and we've got questions. So direct him. Kaylee's going to grab the microphone. Sue, yeah, go for it.
Thanks, everybody. Great job. Given the farming and dairy industry landscape of Wisconsin, I'm really interested to hear if we should be doing something in our messaging differently with bird flu or in prep for anything that might come around bird flu to help build trust, build, all the things we've talked about, local experts, more strategy around the communication plan.
I can go ahead and take that one. So I was briefed recently within the last 6 or 8 weeks about from the state strategy in terms of like what is already ongoing in the H5 space. I think that communication of exactly what is happening is a very comforting thought, right? And the way farmers already take into account any sort of illness that they see within cattle. As you had noted, the dairy farming operation is where we are likely to see any sort of a transmission in that space. But I think that if we can highlight sort of the safe farming practices that are already taking place, that are effective enough against everything, let alone the bird flu, I think that it would set a lot of people's mind at ease in terms of what's going on.
Okay, we have 2 more. I see you.
Hi, my name's Walker. I'm a pre-nursing student here at UWGB, and I was just curious listening. There's a lot of interesting takeaways here, but what can we do to take these lessons we've learned from COVID and incorporate them into not only health sciences like nursing, but also journalism, to get ahead of, like, say there was the SARS outbreak of 2005, MERS in 2015, COVID, we're overdue for a flu pandemic. How can we incorporate these lessons into education so that way we don't have to suddenly get ready? There's already individuals that are understanding what's going to be happening.
I didn't pay you, did I?
No.
I mean, that's precisely why we're holding this panel. It's great.
Right. What are y'all going to be doing, I guess?
we'd like, that's.
I'd like more lunches personally, but that doesn't help.
Yeah, we don't know each other, but I mean, that's precisely what these two studies are doing. And we're hoping this panel will ignite some interest in doing some of the things the panelists have been talking about to strategically and more effectively communicate and literally bring together the journalism and that Tom is talking about, Danielle's talking about, with all the expertise that we have from the medical community. So it does need to change. Actually, the second study that you can all get a copy of, it identifies that that's one of the major gaps that's happening right now. How to work with journalists like Tom and Danielle, and then how to craft messages in a positive way. Go ahead.
That is such a great question. Thank you. Because what our second report, so you might want to read just what the education system, and it's a little surprising. I don't know, maybe Phil, you weren't surprised. I was a little surprised at the lack of communication training in medical schools and medical education and in nursing education. It's not, like we don't get trained in your field either. And those types of things is what we are kind of proposing, that if you don't have some core communication classes and media training as a part of your medical education program, think about that, because it isn't going away. And these are partnerships that are very, very, very valuable. So
Yeah,
you'll find that report interesting, I think.
that's great. I
Yeah.
think it might be helpful for everybody to think about it as a force multiplier. One nurse can only care for so many people at one time, but the amount of prevention you can do with good communication is just, the value of that. So this is good to see, but yeah, I hope something works out.
Well, I would just tell you this, that the Tommy Thompson Center funded all this research because they recognize the need, and they're always on the cutting edge of what's going on out there. And so we saw this as an issue. Danielle and I and Kaylee all saw this as an issue, and we're trying to bring people on the team. So we're hoping that'll happen. And speaking of journalists, how about if we end the session with one question from our professor of journalism, Professor Review? Yeah, you had to put your hand up, didn't you?
Yes, I'm a professor of journalism. Yes. My question is about generative AI. Generative AI. First, I would like to ask whether do you trust generative AI in terms of this kind of crafting health message and getting health information? And second, I'd like to know whether your organization adopt the usage of generative AI. So that's my question.
So we have started to use some AI in our communications, just simple Copilot, etc., but not beyond that. And I don't have enough experience with AI's messaging techniques yet to know if I would trust the way they're rephrasing things to make it more understandable or palatable. But it's definitely an area worth exploring in the future, for sure.
And I'll just add one thing. The study that you can pick up over there has an appendix generated by AI. And it's about the nursing programs and medical training. And it goes back to your question before. And we asked the question, how effective is medical training? We asked ChatGPT, how effective is medical training at dealing with strategic communication issues? And it was a glowing report in AI. It was far more glowing than what we found in our actual study. So that shows that there are some differences between what AI is generating and what we are finding on the ground by going. So we went back to your lesson, Mike. We looked at what's on the ground, not what we're hearing from before. So that's very helpful. I want to thank all the panelists. You guys are incredible. I wish we could go for another 3 hours because I think we could tell the CDC what they need to do next time. And we could help train them and do everything. And you guys really are the cutting edge of helping make some of the changes you just advocated that we make in nursing education, medical education, and certainly something those of us in the communication field have studied for quite a while. And with that, I'm going to turn it back to Christine to wrap up the program. We appreciate you all being here. We hope you lunched and learned, thanks to the Tommy Thompson Center.
Well, as Dr. Phil said, I always chuckle when I say that. As Phil said, we want to thank you for joining us today and to the panelists for their great expertise. I have a lot of questions, but I'll hold them because we could be, as you said, here all afternoon. But there are a lot of lessons to take away from COVID, and you've expressed several of them. And the fact that we still don't completely understand. A 90-year-old, and there was no way to know who was going to be affected. And so it resulted in a very conservative and extreme approach to protecting the public. And I'm glad you asked the question you did, Walker. I really need to have a conversation with you. But we have a lot to take away and to learn. Communication takes all forms. Media communication in a health profession program. How can we do it justice? But perhaps what we really need to do, and it embodies what UW Green Bay is really all about, is that interprofessional and interdisciplinary collaboration that we need to establish. There is nothing suggesting that we couldn't have more of these kinds of events with journalism, communication, health professions program students. And then we can also do a lot more at the graduate level. So on that note, I want to, again, extend our appreciation for your opinions, your experiences, and probably a little bit of PTSD as you think back to all the things you went through in preparing for today. We are a better society, and we will get through this and hopefully be a lot more strategic in the next epidemic.
Thank you, Christine. And thanks to all the people you see on the board here, Ruth Brash, and she's watching on video right now. Laura, where are you, Laura? Laura is incredible, working for the advancement office. Christine, as we mentioned, Kaylee, and then Maddie, Elsie, and Emma, you guys helped as well. And so we had a great group, and Danielle was a great partner. And let's just give one more round of applause to this incredible panel. They are amazing. Thank you. Thank you all.